Okay, it's 10 o'clock. We'll call the meeting to order. Welcome to the Grey Bruce Board of Health meeting for Friday, September 23rd, 2022. We'll start with the roll call. Mary, please.
Sue Patterson,
Present.
Alan Barfoot,
Present.
Brian Milne,
Present.
Brian O'Leary,
Here.
Chris Peabody,
Present.
Luke Charbonneau.
Here.
Selwyn Hicks,
Good morning. Here.
Helen Claire Tingling,
Good morning, Mary.
Janice Jackson,
Here.
Nick Saunders sends his regrets.
Thank you, Mary. All board members are in attendance. At this time, I'll ask if there's any amendments to the agenda, and I have two. Under 11.1 on the in-camera, I would like to include the general nature of why we are going in camera. So 11.1, I'm adding regarding a legal claim that has been renewed. And 11.2, I'm adding, this is for the purpose of education or training board members, I'm adding regarding the survey for board performance evaluation, just to give the general nature of why we are going in camera. And I'll ask if anyone else has any amendments to the agenda at this time. Seeing none, I'll ask for a motion to approve the agenda as presented. I need a mover and a seconder. I have Helen Claire and Brian O'Leary. All in favor? That's carried. And again, I'll ask, everyone can hear me? Yes, very good. All right, does anyone have a disclosure of pecuniary interest or a conflict of interest? Seeing none, if one should arise during the meeting, you may declare it then. So item 5 is our educational notes, and following our theme of professions in public health, we're going to learn about the registered dental hygienist. So a registered dental hygienist, also known as RDH, this position requires a minimum of a 3-year diploma from an accredited college. The RDH must hold a current resignation and must be a member in good standing with the College of Dental Hygienists of Ontario. An extensive continuing education portfolio is also required to be maintained and submitted upon request by the college. Current CPR and first aid training is mandatory for licensing. The Grey Bruce Health Unit also requires that the registered dental hygienist must be self-initiated in accordance with the College of Dental Hygienists requirements. And I'm going to turn it over to Dr. Era to explain what self-initiated is.
Thank you, Madam Chair. Self-initiation means the practitioner has autonomy it has a license to practice without written order from a dentist, and to do so, the practitioner needs to work minimum of 2 years, around 3,200 hours under standing order from a dentist. It's a lot of work to gain that experience. So our staff are already licensed as prerequisites.
Very good, thank you. That was one word I didn't understand, and even when I looked it up, I didn't understand it. So, all right, so training skills and knowledge. A registered dental hygienist must have working knowledge of dental hygiene services and programs as outlined in the College of Dental Hygienists of Ontario Dental Hygiene Standards of Practice. An RDH must have the ability to communicate information, ideas, and opinions clearly, effectively, and appropriately, both internally and externally. An RDH must be committed to acquire and maintain the knowledge and skills to meet the public health core competencies. Must have working knowledge of current dental software and the other ministry recording systems. A registered dental hygienist demonstrates organization and planning skills, must have specific knowledge of health unit communication systems and accuracy, and work as a member of an interdisciplinary team. An RDH is also committed to a safe and healthy work environment for both employees and clients. So roles and responsibilities. The registered dental hygienist plans, develops, implements, and evaluates a variety of oral health programs to meet the Ontario Public Health Standards and practice within the college requirements. This includes applying leadership skills to support seniors and children in local communities through effective program delivery, navigation, advocacy, and policy development and promotion. The registered dental hygienist also builds partnerships and provides services to Indigenous and Mennonite and Amish communities. So school screening includes dental screening of children in select grades in schools throughout Grey and Bruce counties. Healthy Smiles Ontario is offered to eligible families. And the hygienist is responsible to ensure treatment is completed through case management guidelines according to Public Health Ontario and oral health protocols. Preventative clinics. The registered dental hygienist is responsible for providing oral health through preventative clinics in various locations within the Grey Bruce Health Unit dental clinics within Grey and Bruce counties. Eligible HOS clients between the ages of 0 and 17, as well as eligible clients 65 years and older within the Ontario Seniors Dental Care Program, are treated in these clinics. The registered dental hygienist is responsible to ensure there are no contraindications to treatment according to the client's thorough medical history. The registered dental hygienist is trained to handle medical emergencies that may occur at any time. Are there any questions about the roles and responsibilities of registered dental hygienists? Stolen?
Not a question, but maybe just a reflection. Maybe I'm showing my age, but I remember the day when you would go to the dentist and you would see the dentist. And, you know, the hygienist was somebody that, you know, held the tool and got the stuff out of your mouth and passed tools to the dentist and on. And it seems, and is there a difference between a hygienist, a registered hygienist and a dental assistant? And maybe there is, but it just strikes me that there's an evolution there, because now when you go to the dentist, really, I'm seeing the hygienist. I see the dentist for about 3 minutes at best. Maybe others had that experience, but literally, they come in and they talk to each other in a language I don't understand. And then the dentist leaves and onwards I go. And maybe the evolution of healthcare, maybe even medical care is going to turn that way. It might come the day when I go to see the doctor and I'm really seeing the nurse. And the doctor might come in for 3 minutes or not at all. And then off I go. So it's just, I mean, which time I see, you know, when you're a registered dental hygienist, there's, I read here, a skill set, there's the training, there is a protocol, there's, you know, competencies that are expected. And, you know, what a wonderful career for someone to enter. But it might also help in terms of healthcare, in terms of making it more available in proper dental hygiene for the public in general, that we augment the role of hygienists.
Dr. Ayer, did you want to comment the difference between the hygienist assistant and the registered dental hygienist?
Certainly, thank you, Madam Chair. So I can comment on our program here. The dental program has 5 dental hygienists, has 7 dental health educators, which again have similar to what you mentioned, certain skill set that is different for the task that they do and the objective that we collectively achieve. There are 2 contract dentists in the program, and there is 1 program assistant and the program manager. So there is a team of people who have different skill sets. How the dental staff or the dental sub-professions develop, I'm not the expert in, but I know that it has complexity beyond what it was years ago. I know from our staff, the dental health educators, they go to school, they go to different settings, and they do screening, proactive screening. There is a mechanism actually to ensure that the parents have followed up with whatever recommendation there is, whether internally to our program or externally in the community. And it is definitely with a level of complexity that requires the subspecialty, if we can call them so.
Okay, thank you. All right, we'll move on the agenda. So item 6, the first one, 6.1, adoption of minutes. These are the Board of Health Executive Committee minutes from August 25th. It was an in-camera meeting we met for the purpose of educating or training members. So I need a mover and seconder to adopt those minutes. Alan and Helen Claire, all in favor? That's carried, thank you. 6.2 is the Board of Health meeting minutes from August 26th. And I'll ask if there's any discussion with those minutes, questions or comments. Seeing none, I'll take a mover and seconder to adopt those. I have Brian Millen and Luke, all in favor? That's carried, thank you. So we're on to correspondence and news releases, and we do not have any correspondence this month. So we'll move right into the news releases and welcome Denise.
Thank you, Madam Chair, and through you. This month's agenda includes 5 media releases. 3 relate to public health's work and harm reduction. The first is on International Overdose Awareness Day, which was August 31st, and it was an opportunity to raise awareness about the opioid crisis and harm reduction strategies. This release also included information on community events that took place locally to mark International Overdose Awareness Day. On August 29th and September 16th, Public Health issued media releases regarding reported drug overdose deaths in our area. In both releases, GBHU emphasized its call for people to not use drugs when alone and shared harm reduction strategies. The other 2 releases relate to COVID-19. On August 30th, Public Health urged residents to exercise caution due to the BA.5 variant. GBHU encourages everyone to stay up to date on their COVID-19 vaccinations and increase layers of protection when visiting long-term care facilities. And on September 12th, Public Health announced the Moderna Spikevax bivalent booster would be available to eligible individuals at public health vaccination clinics and via community partners. So until September 26th, the booster is available to the most vulnerable residents, and starting September 26th, all Ontarians age 18 and over will be eligible. And that concludes the news releases.
Thank you, Denise. Any questions or comments regarding the news releases? Seeing none, I will ask for a mover and seconder to receive as presented. Selwyn and Alan, all in favor? That's carried, thank you. Item 8 on the agenda is a staff presentation, and we have Lindsay Johnston, who is a vaccine preventable disease program manager. Welcome, Lindsay.
Hi, everyone.
Hello.
Share screen.
There we go. Go back.
Is that the right, is everyone seeing just the slide?
Yes.
Yes,
Yeah.
okay, excellent. Okay, I will begin. So good morning, everyone. My name is Lindsay, and it is my pleasure to be here today to represent the Vaccine Preventable Disease team and provide you with an update on COVID-19 vaccine in Grey Bruce. So in this presentation, I will provide you with a recap of COVID-19 vaccine work completed over the summer, provide you with a look into the current state of vaccine uptake and coverage in Grey Bruce, review our COVID-19 vaccine fall plan, provide an update on COVID-19 vaccine inventory and supply, and give a brief update on our fall plan for routine immunizations and influenza. This summer, we saw 4 significant developments in the Ministry of Health COVID-19 administration guidelines. On July 13th, second booster eligibility was extended to include all individuals 18 plus. On July 14th, pediatric Moderna COVID-19 vaccine was approved by Health Canada for ages 6 months to 5 years, and administration of this vaccine began on July 22nd. On August 19th, Health Canada authorized pediatric Pfizer boosters for ages 5 to 11 years, and administration went live in Ontario on August 31st. Finally, the bivalent Moderna booster, which is the recommended vaccine for fall booster doses for those 18 years of age and older and 12-year-old immunocompromised individuals, was approved by Health Canada on September 1st. Administration began in the province on September 12th for this vaccine for high risk and priority populations. This eligibility is expanding on Monday, September 26th to all individuals 18 years of age and older. After each COVID-19 vaccine-related ministry update, I work with Dr. Zayed and communications to summarize the information for media releases, social media, and create direct communications to our primary care, pharmacy, and congregate care partners. I also work with my team to educate them on the updates so that they can answer incoming questions from the public and healthcare providers. The VPD team receives, on average, 150 calls per week, and more than 1/3 of them are related to COVID-19 vaccine. So this summer, the VPD team delivered and supported 30 clinics throughout Grey Bruce. 13 of these were community COVID-19 clinics planned and executed by the VPD team in 9 municipal locations across Grey Bruce. We also coordinated, supported, and supplied vaccine for 17 Govox COVID-19 clinics. These clinics were strategically planned in areas of Grey Bruce with low uptake, such as Ripley, Teeswater, and Mildmay, as well as areas of high uptake, such as Owen Sound. We worked closely with our decision support team and communications to determine where our areas of low uptake are and how to best reach them. 5,600 vaccinations were delivered this summer at public health delivered and supported clinics throughout Grey Bruce. The majority of these were 4th doses and primary series doses for those 6 months to 11 years. The clinics mentioned on the previous slide represented 33% of the total COVID-19 vaccinations administered in Grey Bruce this summer. The health unit also supported congregate settings such as long-term care, retirement homes, and community living, pharmacy, and primary care to deliver vaccination by delivering vaccine, providing education, and COVID-19 vaccine developments, in addition to cold chain support, IPAC support, and vaccine administration documentation support in Govox, the ministry's COVID-19 database. The graphic you see here represents booster dose uptake and coverage by health units in the Southwest region. Grey Bruce has 59% of residents 12 years of age and older vaccinated with 3 doses of COVID-19 vaccine, and 47% of the population 60 years and older vaccinated with 4 doses. As you can see, vaccine uptake in Grey Bruce is consistent with for 3rd and 4th dose uptake in the Southwest region. This graphic, generated by our decision support team, illustrates the percentage of the population 5 years and older with a primary series plus 1 booster dose of vaccine completed for each municipality in Grey Bruce. Huron, Kinloss, and Southgate continue to be our lowest areas of uptake, and we will continue to provide and seek out opportunities to support these areas. On Wednesday this week, 2 of our nurses attended the Southgate Seniors Fair to provide bivalent boosters and COVID-19 vaccine information to Southgate residents. As you can see, we continue to see our highest uptake in the Northern Bruce Peninsula, the Blue Mountains, Saugeen Shores, and Kincardine. Significant planning has been done over the summer to prepare for the fall respiratory season. For COVID-19 vaccine, primary series vaccinations for 6 months to 11-year-olds and and 5 to 11-year-old monovalent boosters, as well as bivalent boosters for high-risk populations in long-term care, retirement homes, other congregate settings, First Nations, Inuit, Métis, pregnant individuals, immunocompromised individuals, and those 70 years of age and older will be prioritized. Bivalent boosters will be the recommended vaccine for individuals 18 years of age and older, as they have been shown to elicit superior neutralizing antibody responses against the original strain of COVID-19, Omicron BA.1 and Omicron BA.4 and 5 variants. Estimated September to December COVID-19 vaccine demand was provided to public health units in early August by the Ministry of Health to assist with fall planning. These estimates were based on previous booster uptake and demand. The next slide will demonstrate how we plan to meet these estimated vaccine demands. So using the delivery channel percentages from the summer for pharmacy, primary care, and congregate settings, and the estimated demand numbers from the Ministry of Health as targets, the number of required vaccinations by the health unit was calculated. These numbers were then used to determine how many clinics would need to be planned to provide capacity to meet the demand. So as you can see on the slide here, in October, we have the capacity to complete 9,400 COVID-19 vaccines from public health units supported and run clinics. Health unit community clinics for September to November are planned at a frequency of 1 to 2 times a week with a capacity of 700 vaccinations at each clinic. Strategic outreach clinics have also been planned to provide support to our high-risk populations. We have been very fortunate to have formed partnerships with Keystone, Saugeen First Nations, the Chippewas of Nawash, SOS, Mawikwadong, and Gray and Bruce EMS to facilitate vaccine delivery to these priority populations and support equitable distribution of COVID-19 vaccine throughout Gray Bruce. Clinics with Govox have also been organized at a frequency of 2 to 3 times per week. Each Govox clinic has a capacity for about 300 vaccinations. Throughout the fall, we will also continue to provide strategic communication, COVID-19 education, COVAX education, adverse event following immunization consultation, cold chain and vaccine inventory support to our primary care, congregate care, and pharmacy partners. The VPD team is responsible for all publicly funded vaccine inventory management in Grey Bruce. There are currently 5 COVID-19 vaccines that we order from the ministry, store and maintain cold chain for, pack and deliver to clinics and our community partners. COVID-19 vaccine uses a separate inventory management database called COVAX that I've mentioned in a previous slide. This database is consistently monitored and maintained by our program assistants. Program assistants also report daily on COVID-19 inventory counts and perform weekly cycle counts that I analyze to ensure consistent supply of vaccine and perform required inventory reconciliation. COVID-19 vaccine orders are currently being fulfilled by our 2 delivery drivers on a bi-weekly basis. I'm very proud to share that over the summer, we achieved a 99% on-time and full delivery rate for COVID-19 vaccine orders. While COVID-19 vaccine distribution and administration is a significant priority this fall, my team will also be working hard to address the ISPA and school vaccine backlog that has resulted from the COVID-19 pandemic. Yesterday, we completed our first of 51 school vaccine clinics that are planned between now and November 9th. Next week, we will also be receiving our first shipment of influenza vaccine and will be packing and delivering orders to long-term care, retirement homes, hospitals, primary care, and other community partners. Thank you all so much for your time today. If there are any questions, please let me know.
Thank you, Lindsay. Are there any questions or comments for Lindsay? Brian?
Thank you, Madam Chair. Good presentation, Lindsay. Thank you very much. My question regarding the interval, or if an interval is needed between the bivalent COVID-19 and the regular flu influenza vaccine administration. Is there any kind of guidance there?
So NACI and the ministry have both come out with guidelines that for anyone over the age of 5, co-administration of flu vaccine and COVID-19 vaccine is approved, as well as any time before or after. So there's no interval required between flu and COVID-19 vaccine, except for that 5 years of age and under, and that's just as a measure that's been put in place, just precautionary.
Right. So, Madam Chair, if I might have a follow-up then, would it be more efficient, I suppose, to offer the seasonal flu shots at the same locations as the COVID-19 clinics? Or maybe that's going to happen. I don't know.
So what we have organized right now is we are partnering with a few of our community partners to deliver clinics for their staff, for residents, community members. And in those scenarios, in those kind of smaller clinics, right now we are planning to offer co-administration and bring both vaccines. And I think it's something that we will look to see if we can accommodate. Right now at our COVID clinics that we're doing in the community, there's 5 different vaccines that we're offering to a very wide range of population. So my only concern there, doing them in those larger settings would just be kind of having to send, and there's 4 flu vaccines that we're receiving. So just the magnitude of different vaccines and the potential for error, and just slowing down kind of our ability to address that large demand of COVID-19 vaccines that we're able to offer if it's just COVID that we're doing. So again, it is something that we are considering, especially for those smaller clinics that we're facilitating.
Very well. Thank you.
Any other comments or questions, Alan?
Thanks, Madam Chair. Great presentation, Lindsay. And I'm not sure this is a question for you or Dr. Era, but things seem to really open up now. I mean, everything's open, everybody's out and about, but you still hear a lot of people getting COVID. So is there a way that we're monitoring to say, in the area we had so many cases yesterday? Because I don't know how it would be tracked, but if there's a way that it is tracked, I'd be curious to know.
Through you, Madam Chair, we definitely continue to have the same monitoring level in the testing in the high-risk sector. And we do report it to our dashboard online. We don't publicize it just because the communication to the public needs to balance increasing concern when concern is needed and decreasing concern when it is not. And we found at the end of the emergency, and this is the norm to be found, where people are still having this high level of concern. So we had to actually intentionally reduce their concern by reducing the number of our updates instead of daily or twice a day to once a week or so. But we do monitor the trends, and in the item under the MOH update, there will be data on this transmission.
Luke?
Thank you, Madam Chair, and thank you, Lindsay, for that information. I was just interested in the flu vaccine, and you mentioned that the vaccines to arrive the week of September 26th, next week, and the distribution starting to long-term care and the high-risk settings. But I wonder, do we have a sense at this point? I read the press release from the health unit yesterday saying we had a case of influenza A in the region. I just wonder, do we have a sense of when we will have enough vaccine to start to immunize the general population?
Sorry about that. Yeah, so our intention is so we're allocated a certain amount that we get pushed to us next week. And our intention is to get it to primary care as well as soon as we can, so they can start administering. I don't, and potentially maybe Dr. Zayed knows the exact dates that it kind of opens up, but those those high risk individuals are prioritized in that first. I think it's through to kind of the end of October, and then it kind of opens up to the general public in We were told in November, but it may be, and potentially Dr. Zayed can comment on whether there's any updates on whether that will be earlier because of the earlier onset of the respiratory season.
Dr. Zayed?
Through you, Madam Chair, there is one case yesterday but it doesn't mean that we have an early surge of influenza. We are with the information that we got from the Southern Hemisphere that there is an early season from Australia. So we might have the same profile. But for now, there's still the weekly surveillance shows that it is a low risk. However, we will have the liberty to start the delivering as soon as possible. So it doesn't have to be in November. We will, as soon as we get it and cover the high priority and long-term care, we will open it to the public. And probably the weekly surveillance that is happening through Public Health Ontario and through Public Health Agency of Canada, if there is increased risk and the change in the risk for the weekly surveillance, we definitely will expedite the delivery for the public.
Luke?
Yeah, thank you, Madam Chair. And just another question also related to the flu, I guess, and also COVID-19 with so you showed us the map of the region showing COVID-19 uptake in the various municipalities. And I just wonder, does that mirror the uptake for influenza vaccines that you see? Do we see the same differences across the region historically with uptake for flu vaccines as we're seeing with COVID now?
Lindsay or Dr. Zayed?
I'm honestly not sure, but I do have data. We have data on that we were provided from the ministry on the administration. And I'm not sure. So the ministry changed it this year so that we're to try to limit wastage. We're sending primary care 50% of the doses that they received that they administered last year. So I'm not sure traditionally with Govox, which we use for COVID-19, we have accessibility to a very wide range of data that we can then pull from to create, these maps and things. But potentially with the data that we were provided from the ministry, and this is actually from primary care billing statistics. So I'm uncertain whether we usually have access to that, but what we potentially could look into is creating a similar, kind of a similar map using that information from primary care, at least to see if there is a similar, similar trend across the two counties. I'm not sure if you have anything to add, Dr. Zayed.
Through you, Madam Chair, there is, of course, surveillance about influenza from before, and it is a very strict and accurate surveillance. The influenza uptake, usually in the public in general, does not exceed 45%. There is more increase in the priority population above 65, which is the age of more of morbidity and mortality, and it is around 65%. It is more in long-term care facility and regulated facilities. So it is between 45 and 65%, more or less like a little bit higher than the COVID vaccine for the seasonal influenza in our area, but it is around this percentage.
In fact, just to conclude, Madam Chair, I just think that if there's a trend that we can see in influenza uptake, but in differences between Kincardine and Blue Mountains or whatever, then over time, if we can establish that, it could help us to target our activities and do different things in different parts of the health unit to make sure that maybe we can get that uptake to be more even across the region. So certainly something to monitor going forward and to work on. Thank you, Madam Chair.
Thanks, Luke. Dr. Era?
Thank you, Madam Chair. I wonder, Lindsay, if you can share the slide for the map, please. I echo what Dr. Zaid and Lindsay mentioned about the flu and the map, but I just want to add a few things to it when the map comes up. In general, there are, until the map comes, there are different variables that affect the uptake of vaccines in general, but there are also variables that affect the uptake of vaccine specifics. So one of the general variables is religion belief, and we know that throughout variables there are groups who have certain beliefs that might not be very supportive of vaccinating everybody. That's one. There are general factors related to the effectiveness of the healthcare system components. Primary care, for example, usually vaccinates 70% of the population. Now, from the data that we've seen, it's around 8% instead of 80 or 70. So this is a general factor, but also you look at specific factors. With the flu, there are certain seasons where there is a good match for the vaccine, and that will increase the uptake. Other seasons where the vaccine is not a good fit for the circulating bug. So again, it's very difficult to compare data throughout. I want to point out here a point that's not related to this, but you look at the Saugeen First Nations and Naywak. In the map, it is completely wiped out, not because there is no coverage. Rather, we don't report on data from First Nation without their permission. That's out of the respect to the OCAP principles, the ownership and custodian principles of the data. You look at the South, we know that there are communities that have Amish and Mennonite communities, and that doesn't mean that they don't have immunity. Many of them had exposure to the virus itself, which generate immunity. So that might really become a factor specific, not specific for COVID, but specific for a region. Again, to the best of our ability, we look at the data and we try to infer from it to optimize our operations on different fronts. But it is very difficult to just use the two maps from two vaccines to do that without taking it with a grain of salt. Thank you, Madam Chair.
Okay, so any other questions or comments?
One more comment, Madam Chair, sorry, related to the initiation or the start of the flu vaccine. There are also variables or factors related to the lasting immunity. So we know the flu vaccine has immunity that wanes over time. And if we start the vaccination in September, guaranteed by March, many people would be exposed to the end of the season. So it is the best practice to hold back until we have evidence from surveillance that there is circulation that warrants starting the campaign. Again, there are details to when those decisions are made, and obviously communication with the ministry, the availability of vaccine, the availability of the healthcare system to deliver the vaccine, and we do our best to balance it for the best interest of the community. Thank you very much.
Thank you. Brian?
Thanks, Madam Chair. Dr. I just want to go back to the monitoring of the vaccine or the COVID trends. How do you get the information when the average person now just try to test themselves and realize that they have COVID and then they just carry on?
So we do, through you, Madam Chair, we test in the high risk sectors, primary care, not primary care, long-term care, hospitals. Those institutions have testing policies that are consistent. So this is a proxy to what's happening in the community. It's not, when you cannot get a clear glass, you get the clearest glass you can get. So it's not going to be a robust assessment of the circulation in the community, but it is a reasonable proxy.
All right, Lindsay, I have one question. Can you speak a little bit about the Govox Bus? Would it be available, say there was a large company that had 200 employees, would they be able to book the Govox Bus, or even like a smaller group of businesses in a business park or an industrial park, would they be able to book that bus and have the health unit come in and give the vaccine?
Yeah, so Govox does offer that. We usually communicate, to organize, communicate with them to organize the clinics. But for sure, if there was an organization that needed support with vaccination, we could definitely organize something through Govox to visit their facility. Either, they offer the buses, they do indoor clinics. So as long as they had kind of the space available and could coordinate that, then yes, we could definitely do that.
Very good, thank you. And I don't see any other questions.
Helen.
Oh, Helen Claire, yes.
Thank you,
Sorry.
Madam Chair. Through you, just very, very interesting presentation. Thank you, Lindsay. Two questions. The first, I'm trying to get a greater understanding of the map, the data. I understand that certain populations, the uptake of the vaccination is greater. So I'm just wondering if the fact that Saugeen Shores, Kincardine, Blue Mountain, the peninsula, does that correspond to a higher population of senior age? Is that the situation there, or is there something else? That's my first question, Madam Chair.
Lindsay or Dr. Zayed?
I can take this question, Madam Chair.
Okay, Dr. Era is going to answer.
It's a very good question that raises complex potential answers. If you look at the map, the very northern peninsula, there is a very clear answer to that question. The family health team did an amazing job during the pandemic. In July 21, when the province was pushing for the 70%, that area had around 94% in their group of patients. Family health team of 8 physicians and the number of nurses, and they were very committed to that cause. That's clear-cut answer. But when you go to areas like Kincardine, there are multiple factors that come into play. And in general, in Grey Bruce, the location of access, to the best of our ability, we try to mitigate that. Like in Northern Peninsula, it's not a very accessible area, but we compensated by sending the support that is needed for that area. The primary care did their work in certain areas. I mentioned religious belief could play a role, but again, it's not. None of these factors is 100%, specifically not in one location. It's different. Not sure if that addresses the question.
Go ahead, Helen Claire.
Thank you, Madam Chair. I'm sort of building on something here with thanks to Dr. Ara. Dr. Ara earlier spoke about the need for messaging to match the fact that we are now in a situation of decreasing concern. But I also see that our region is all over the map. We have high uptake, we have minimal uptake in 3 areas, and then we've got sort of West Grey kind of, loosey-goosey. The uptake of 3 shots right across the board, where we've just seen is less than 60%. So I'm just wondering if we as a population in Grey Bruce vulnerable, since we have less than 60% who have 2+1 boosters, and there are big patches where that uptake is not very much at all. I just wonder if Dr. Ara could answer that question. Thank you, Madam Chair.
Dr. Ara.
Thank you, Madam Chair. I wouldn't say we're in a less favorable position. If I can ask Lindsay to put up the data from the Southwest region. We are in the middle for the number of doses or coverage for 3 and 4 doses. We need to remember that many people have already acquired COVID, and that generates immunity. And usually the natural immunity is as good or better than the vaccine. And some people got the disease multiple times, got multiple boosters. Is it going to prevent circulation of the virus? No. For measles, for example, we have to reach 94% or above, 92 or above to prevent the outbreaks. But again, with COVID becoming a weaker strain with every variant, we need to go back to basics. When you look at COVID-19 is one of the corona family, and corona family has 4 other strains that affect humans, also known as common cold. So in 2020, it's a novel virus, can cause severe disease. In 2022, it is way less severe. And the data that we have from the past 9 months would show that most people who died with COVID diagnosis died with the diagnosis, not because of the diagnosis. So again, you put the level of vaccine in the community, the level of the immunity from the wild virus, from the virus itself, we're not in a different situation from other parts of the province. And this is the data which show us right in the middle, actually. And the difference between health units among health units is not significant.
Helen Claire.
Thank you very much, Madam Chair, and thank you, Dr. Ara, for a comprehensive response.
Okay, any, Brian?
Thanks, Madam Chair. Sorry, last one. I'm just wondering about the mandated vaccines now for long-term care workers and hospital workers. Are we past that now?
If I can turn the question to Dr. Zayed and Lindsay, they would know the details from these facilities. And the reason I'm turning it just because there is a policy from the province and there are policies from healthcare institutions themselves. They're entitled to have more rigorous policies.
Dr. Zayed?
Through you, Madam Chair, with regard to vaccine, it is for the COVID vaccine, staff, it is an internal policy based on the long-term care facilities. Most of them have mandated vaccines, and there is a sort of, when there is an outbreak, there are people who are not completed vaccination. They are not allowed to work during an outbreak time. For influenza, we have policies from previous, and it is still valid, that there is, of course, there is a vaccine, and again, it depends on the internal policy of the hospital, but the setting. But for outbreak setting or outbreak situation, staff who are not vaccinated are not allowed to work, and they have to take the prophylactic treatment for influenza. So there are some policies that allows some options in the facilities, and there are policies that are mandatory during the outbreak situations.
So just to follow up, so if I'm understanding that right, then if it's an internal policy and a long-term care home decides they're not going to mandate vaccines for staff and there is an outbreak, then we could be in big trouble.
There is always a plan that with options. For example, we have different outbreaks in long-term care facility. Most of them are mandating the vaccine, actually, and the staff vaccine there they have a high percentage. But again, of course, this is something. If there are people who are not taking the vaccine and are not at work, this will be also another problem. We have problem with shortage of staff in the long-term care facilities. So the internal policies allows this kind of graded approach. If there is an outbreak, they have always a plan in place for cohorting. Like it's by itself a detailed process. So there is a plan for cohorting staff, plan for partnering with agencies, because it happens that the staff vaccine mandates have not been successful in even achieving the 100% or the high percentage with a mandate.
Great, thank you.
All right. Lindsay, thank you very much. Good presentation, and we had a good discussion. So thank you very much. Moving on with the agenda, item 9 is the medical officer of health update, and we'll start with 9.1, Dr. Era.
Thank you, Madam Chair. If we can put the presentation, please. So, Madam Chair, this is a set of data that comes from the province, and we can go to the next slide. It usually contains information from the past 2 weeks or 1 week, depending on the slide. So in general, in the province, you would see the number of new cases is decreasing by around 10%. The number of deaths related to COVID by decreasing by 14%. Positivity rate is increasing slightly 2%, but again, I mentioned before, positivity rate has its own way of interpretation. There are many factors that comes into it, depending on the number of tests and the type of testing. Outbreaks is decreasing, hospitalization is decreasing, and ICU is decreasing. So this is a very reassuring picture, but if you go granularly, and we'll go in the next slides, we'll see, not in this slide, but in another one, we would see a bit more different picture depending on the health unit. This is different jurisdictions across the world, and you would see Ontario is in the middle, and it is decreasing from the previous updates that I provided. It's around 70. I wonder, Kaylee, if you can go to Ontario and do it person. It's around 70%, 70 per 100,000 population. Then, and it is, as I mentioned, decreasing. If you go to the next slide, please. This is by health unit, and you would see some in the blue increasing slightly, in the green decreasing. Gray blues is again in the middle of this. It's around 50 new cases per 100,000. And again, this is in the high risk sector. So you adjusted, but you look at the trend of it, it is decreasing, which is reassuring. If we can go to the next slide, please. This is in Ontario, number of outbreaks, and depending on the sectors, and we're not looking at all sectors. Schools are not here, for example. But you look at the light color and the darker color. Darker color is outbreaks in the last 28 days. Lighter color is in the past 7 days. And this is reassuring when you see the lighter color is less than the darker color. That means the number of outbreaks that are being cleared are more than the number of new outbreaks. And if you can go to the next one, please. These are the hotspots in the province. And again, there's nothing specific. There's a bit more circulation in these areas. Grey Bruce is not on this list. I believe this is the last slide in the deck. You can go to the next one, but just to make sure it's not related. Yeah, I wouldn't want to comment on Australia. So again, Madam Chair, it's we expected in the fall to have circulation of the virus and continue to exist, and we're not out of the woods until we have the data internationally to show that this is going to be non-issue. However, with this circulation of the virus that we've been seeing, it is still in a relatively good position, not necessitating, not requiring us to change policy or direction.
Okay. Are there any questions for Dr. Era? Brian?
Thank you, Madam Chair. And Dr. Era, I wonder, is it just coincidental that schools are not on that list, or is that intentional? My experience with my young ones years ago was that the schools tends to be a petri dish of disease. So I'm just curious to know what's going on with that, please.
Through you, Madam Chair, it is definitely intentional not to be on the list. This list is for high-risk areas, and the schools with Omicron data, the risk to kids is negligible. The risk of transmission is there for the whole community, regardless whether in school or not. But following up outbreaks in schools has proven at early this year or at the end of last year not to be necessary. Again, we always compare. There are many diseases circulating. We don't screen for them. We don't follow up with them. And Omicron or COVID in general in school has proven to have negligible risk on severe disease.
Thank you.
Any other questions or comments? Selwyn?
Just curiosity, one of the slides showed, I think South Porcupine with almost a landslide drop. Do you know anything about?
Can we,
that?
not specifically on that health unit, but if I look at the pattern, we might infer something. The next slide, the other one.
There it is. Porcupine, see there, yeah.
It's just a sharp decrease. It could be related to many things. I wouldn't want to speculate on other health units, but in general, when we see this pattern, it would be the sample size is small. So any change in the number of cases would show as a severe decrease.
You could say that the porcupine data is rather pointed.
We needed a smile.
Tough
there,
crowd.
man. We're laughing, so. All right, we'll move on. 9.2 is the Youth Mental Health and Addictions Champions. Dr. Eric.
Thank you, Madam Chair. This is a follow-up from last meeting on the school health program, and there was a question from the board on the Youth Mental Health and Addiction Champion. So we provided a detailed information about the initiative, and there's a partnership collaboration with the Registered Nurse Association of Ontario, where funding comes from. School Mental Health and Bruce Power, they contributed as well. And obviously the school boards is a main player in this initiative. Mainly the school identifies 8 students who are champions for health. They're chosen by their peers. They receive a certain training by the initiative. Then they're supported, these students, to provide initiative on a monthly basis. And the goal of the initiative is to reduce stigma of mental illness and increase awareness of the need of mental health. The initiative, the program was evaluated in 2019, has been successful to provide opportunity to promote mental health, wellness, and youth resilience. So just breakdown to follow up on the question from the board.
Thank you. Any comments for Dr. Aaron? Seeing, Luke, okay, yes.
Yeah, thank you, Madam Chair, and thank you for that information, Dr. Aaron. It's a good program, an interesting program. I wonder, in a sort of a related question, and you may not have the answer right now, but maybe you can find it for us. You know, so the reason why we're concerned about mental health is because we want to prevent the very worst outcomes of negative mental health, namely suicide, which is unfortunately something that I'm hearing about anecdotally, not so much in the youth population, but in the adult population or in my area, more and more. And I just wonder, to what extent, I mean, I assume we have statistics on suicide rates locally, and I just wonder, you know, what monitoring are we doing on suicide, both in the youth population and the adult population, and what conclusions are we drawing, if any, at this point? So as I say, that's a detailed question which requires some information which you may not have on the top of your head, and I get that. I just wonder, is it something that we can hear more about going forward? That's the question. Thank you, Madam Chair.
Dr. Aaron?
Thank you, Madam Chair. Excellent question. And like you rightly said, it requires background work to provide up-to-date information. I suspect in general, the update that we'll bring to the board on the subject would show, because of the sample size in Grey Bruce, it will be difficult to provide conclusions on trends or causes. And that report that we'll bring will have data from the province and data from Canada in general, because those trends show up there. And I can give one specific example. In 2020, with the lockdown, with the pandemic, many people, including myself, questioned what's the effect on suicide rate. This is going to be significant, lockdowns. The data that came out of Saskatchewan, and it's the national level data, in 21 was not supportive of that. There was zero increase in suicide as in relation to the pandemic. It's a very complex mental health outcome, and many factors come into it. But we'll bring to the board a comprehensive answer to your question.
Thank you.
Okay, we'll move on. 9.3 Public Health Modernization Update. There is no movement on this at this time. So 9.4 is the opioid situation in Grey Bruce. Dr. Zayed.
Through you, Madam Chair, I just want to update the board about the data and also the projects. So we continue to receive reports on from community paramedics in Grey and Bruce from the 1st of August till present. We had 93% of the report of overdose were non-fatal, with 27 to 29 cases of overdose. 69% of those cases were males with a median age of 39. There has been increase in fentanyl and mixing fentanyl with methamphetamines. So we are trying now to do a sort of more dissection of cases that have overdose in terms of more variables, and getting more information to inform our strategy of prevention, either primary or secondary prevention. Harm reduction, with that we have we increased in our first-time responder reporting to include not only paramedics, but include reports from police, fire services, to enhance the data collection and create a robust analysis for community partners and people who use drugs and the general public. We have increased the number of one part also of secondary prevention. We have increased our number of community partners naloxone distribution to strengthen the equitable and the broad access of life-saving medications. The newest partners include Saugeen First Nation, Métis First Nation of Ontario, Saugeen Shore Fire Department, and the Women's Center. Data reporting for overdose from paramedics also have been strengthened and streamlined for accuracy for the type of opioid and suspected overdose. So we are really continuously working with our partners in refining the data reporting that we get to our dashboard and monthly reporting. With regard to provincial contribution and working with other health units, we had through the COMO work group, we have submitted the project of locally driven collaborative project to Public Health Ontario. So Grey Bruce Health Unit is the main applicant for that project, with other co-applicant including two other health units, Simcoe, Muskoka, and Kingston, in addition to the academic co-applicant, which is a Research Unity Hub affiliated with University of Toronto. We also have knowledge advisor from the Ministry of Health, from the Chief Medical Officer of Health Office, who with the associate chief responsible for the harm reduction and the harm reduction department in the ministry. We have also Porcupine Health Unit as an advisor, as a Northern Health Unit and knowledge user. We have community projects, especially locally. So we have the YMAC, this project as a knowledge advisor and user, and for schools. And there is also the home takeover project, and there is SOS project. So we are using our local community project as the knowledge advisor and knowledge user. And the main importance of this project is to do two things. One is a questionnaire will be distributed to all public health units and key partners about the intervention that they are using and the indicators of this intervention. We will use a literature search, a robust literature search to see the exemplary program, and then we can compare what is and identify the gap in intervention and practice, and put a recommendation or knowledge analysis evaluation report for all the knowledge user and for future improvement of prevention. We are focusing on our group, on the youth who are from age 15 to 25, which is the age we wanted, especially this age and the school age group. We will also get some information about risk factor and protective factor, expanding to early childhood with adverse childhood experience and social determinants of health. So this is the first project. The other project is also, we are a co-applicant on that project to see Canadian Institute of Health Research, and that is a project with it's completing the first one by the end result will be a map and a framework for action for youth and age group of the youth about prevention intervention, and a way of also indicators of how we are doing the work and if it is successful or needs improvement. So that's also an application, and fingers crossed we'll get approval. And when this will happen, we will have some presentation with more details about these two projects. That's my update. Thank you.
Thank you, Dr. Zayed. Are there any questions for Dr. Zayed? Helen Claire?
Thank you, Madam Chair. Through you, there was a great deal of flourish for the first few months of the year amongst all health units and indeed Chief of Police Association and other organizations sending a request for recommendations to the province, and they were pretty uniform. And I just wondered if there had been any response back to those recommendations at this time. Has anything come back from the province? Thank you.
Through you, Madam Chair, we have many of the health units actually through that work group where we're actually asking this question. The information that I have right now that all these letters and the resolution have been received and under process. So we are still awaiting for the response.
Other questions or comments? Okay, thank you, Dr. Zayed. So we need a motion to receive the updates as presented. I need a mover and seconder. So I'll take Alan and Janice. Thank you. All in favor? That is carried. Someone?
I just wonder, Madam Chair, do we really need to have the modernization item as a standing item anymore? I mean, I don't get any hint that the government is planning to move on modernization, but what are your thoughts?
Dr. Era, have you had any information about modernization?
Through you, Madam Chair, not from the ministry, but from discussion with Como, the Council of Medical Officers of Health had a section meeting recently, days ago, and there was a clear discussion that this item will be revived very soon from the ministry.
Okay, very good. So we'll leave it as a standing item. 10.0 is corporate services, and we have Kim Rutherford, our senior finance manager, will present the July financial update. Kim?
Thank you. Through you, Madam Chair, these are the July financial statements. We've been operating at a consistent expense level for the past few months. There has not been a significant change in our financial position from June to July. At the end of July, we had a surplus of $366,000. Most of that surplus continues to be from the seniors dental program. We have various procurement initiatives underway to secure some equipment with that surplus, as well as partnerships with local dentists to increase the number of patients we're seeing. Our mandatory programs and COVID programs continue to be fully funded. Our mandatory program funding is currently covering 1.4 million of our COVID-19 and COVID vaccine costs. So we've only had to utilize 450,000 of the COVID extraordinary funding to fully cover our costs year to date. If we look at our funding and our revenues, with the exception of the COVID extraordinary funding, we're right in line with our budgeted expectations for July. On the expense side, our wages and benefits continue to be under budget, mostly due to the reduction in overtime hours for our staffing. We also went to market for our insurance benefits for our staff. We maintained the same level of coverage, but just at more favorable rates. So we're starting to see some of the cost savings of that trickle in, and we'll see that for the remainder of the year. Building and occupancy is right in line with budget. And similar to previous months, our operating expenses are under budget. There was no notable purchases in July. We do have a few larger expenditures coming later in the year, and programs are planning to utilize their budgets. But financially, we're in good shape. For the Walkerton dental project, we are currently reviewing a lease agreement for a new space for the clinic. And the project team is putting together a request for a proposal to find a project manager to manage the construction component of the job. So that proposal should be going out to bids and tenders within the next couple of weeks.
Thank you, Kim. Any questions for Kim? Brian?
Thanks, Madam Chair. Just a comment. That's the first I've heard of anyone going to market for insurance and getting better rates. So well done, Kim. That's something.
Right. Anyone else? Okay, so we do need a motion to receive the July 2022 financials as presented, moved by Brian O'Leary and seconded by Brian Millen. All in favor? That is carried. So thanks, Kim. All right, item 11 is in camera. So it has been recommended that the Board of Health meet in closed session for 2 items. The first item is to address matters pertaining to advice that is subject to solicitor-client privilege, including communication necessary for that purpose. This is regarding a legal claim that has been renewed. The second item is for the purpose of educating or training the members. And this is regarding the survey for board performance evaluation. So I need a mover to go in camera, mover and seconder. And I have Selwyn and Alan, all in favor? That is carried. So we are now in camera. Does anyone So we are now back in open session, and I declare we discussed only the items on the closed meeting agenda. The in-camera meeting minutes dated July 22nd, 2022 were approved. And we did receive advice subject to solicitor-client privilege. And that was regarding a legal claim that has been renewed. We also received information for the purpose of educating or training board members, and that was regarding the survey for board performance evaluation. We have one final motion we need, and that is to adjourn at 12:01. Moved by Brian Millen and seconded by Selwyn. All in favor? That is carried. Thank you very much. Good meeting, everyone.
Have a good weekend, all.
Thank
Take
you,
care.
everyone.